Afternoon. My name is Lane Wells. And today I'll be presenting our performance improvement initiative focused on extubation times in the CVICU. Over the last quarter, our unit has exceeded the hospital benchmark of 360 minutes for extubation following cardiac surgery. Rather than reacting to service level averages, my goal is to walk through the data, identify gaps, and propose a structured team-based approach to understanding and improving this metric. This is not about assignment blame or pointing fingers. It's about understanding variations and improving patient care. Interdisciplinary PI team. To approach this correctly, we need the right people at the table. Performance improvement works best when it's interdisciplinary. Research consistently shows that collaborative teams reduce bias and improve outcomes. Um, One team should include respiratory therapy. I'll serve as the project lead since we manage ventilator outcomes and ventilator changes. Nursing, they understand post-op workflow. Surgeons, because physician engagement is critical. Anesthesia, since intraoperative management affects extubation readiness. A data analyst to risk adjust properly. Pharmacy for sedation protocols. Case management to assess downstream impacts. If this becomes personality driven, we fail. If it stays data driven and team focused, we succeed. It's not about individuals, more of a team approach to achieving the best patient outcomes. Average extubation time by surgeon. Here's what was presented at the meeting. Average extubation times by surgeon. We can see that Dr. Allen's average is significantly above the 360-minute benchmark, while the others are below. The overall average barely exceeds the metric. But here's the issue. Averages don't tell the whole story. They don't show patient severity, comorbidity burden, case complexity, and outliers. If we stop here, we risk drawing conclusions without context. Got to get the whole picture, not just some of the basic stuff. It's more, sometimes there's more complicated issues that can lengthen that time. Severity versus extubation time. This scatter plot starts telling a more meaningful story. As severity index increases, extubation times also increase. That's not surprising. Sicker patients require more stabilization, more ventilator care, more changes, more blood gases. So the question becomes, is the issue provider performance or case mix? If Dr. Allen is consistently operated on higher severity patients, raw averages may unfairly misrepresent performance. This is exactly why we need risk adjusting reporting moving forward. Additional data needed. Right now, we're missing critical context. Before we make decisions, we need average severity index by surgeon, average number of comorbidities, reintubation rates. That's something that is not talked about a lot. Sedation practices, OR end times, staffing ratios, post-op complications. The EMR has this data, we just haven't pulled it. Without risk adjustment, we're comparing apples to oranges. Risk adjustment strategy. Here's how we'll approach this analytically. We'll compare mean severity index per surgeon, mean comorbidity burden, complication rates, time of day surgical factors. If higher severity correlates with longer extubation times, then our conversation shifts from who is the problem to how do we optimize care for higher acuity patients. That's a much healthier discussion. This avoids pointing the finger at people or departments. Structured team approach. We don't just look at spreadsheets, we'll use structured improvement tools. First, a brainstorming session. Then we'll group themes using an affinity diagram. We'll perform a root cause analysis, then test interventions using PDSA cycles. This approach ensures we don't jump to solutions prematurely. We examine patient process, provider, and system factors. Structured methods reduce emotional bias and increase accountability. Define team roles. Clear roles prevent confusion and defensiveness. I'll coordinate data synthesis and meetings. Nursing will provide bedside workflow insight. Surgeons will clarify case selection and operative complexity. Anesthesia will evaluate the intraoperative sedation practices. Pharmacy will review post-op sedation strategies. The analysts will ensure statistical integrity. Everyone has ownership, no one is isolated, everyone is part of the team. Preliminary solutions. Even without new data, we can propose initial interventions. Short-term possibilities can include a standardized post-op sedation protocol, an early extubation readiness checklist, a daily 0600 extubation huddle. This is something we use common at our hospital here. Monthly risk adjusted dashboards, rapid PDSA testing cycles. Notice these are system level changes, not individual corrections. Our objective is sustainable improvement, not temporary compliance. And here are the references.